Dr. Randy Resnik. I believe this is his 19th appearance on this webinar series. You all know Dr. Resnik. He is the author of multiple textbooks. He runs the Resnik Implant Institute, the finest implant training in the country, maybe the world. And we're just delighted to have him back. He was our keynote speaker at the Implant Symposium and did a fantastic job. So let's turn this over to Dr. Resnik for part 3 of his series on occlusion. And this one is Achieving Ideal Occlusion for Full Arch Fixed Implant Prostheses. Randy, it's all yours.
Thank you, Neil, and the rest of the staff. It's great to be back. I have a lot to go through, so I'm going to get started right away. Our objectives for this lecture is, first, I'm going to go over full arch occlusion terminology. This might be kind of basic. However, I want everyone on the same page when we start talking about the occlusion. We're going to talk about the different occlusal schemes that are available for us for full arch prostheses. Then we'll actually go through the ideal occlusion protocol for full arches. We'll talk about ideal full arch materials. And then we'll talk about the ideal antagonistic arch material, which is a huge question now in our profession, what the other arch should be when we do these full arch cases. And then we'll end up with, how do we minimize post-op occlusion issues? So first of all, if we look at terminology, and like I said, this is going to be a little bit basic, but I just want everyone to have the same terminology. So when we discuss the ideal occlusal scheme, everyone will be on the same page. If we look at occlusion, there's a static way of looking at occlusion. Basically, when the upper and lower jaw is closed and it's in a stationary position. Now, what is that called? Centric occlusion. Some people call it habitual occlusion. It is actually maximum intercuspal position, MIP. The teeth are in maximum contact. So the contact of the teeth are determined by the teeth, not the TMJ joints. In contrast, we have centric relation, which, depending on what definition you go by, it's the position of the condyle in the glenoid fossa, most commonly the anterior superior position. Now, the teeth contact is determined by the TMJ, not the actual teeth. So there is two different types of static occlusion. If we look at dynamic occlusion, this is where the jaw is moving and there's contacts between the teeth, most commonly protrusive, retrusive, and lateral excursions. The protrusive is when the jaw comes forward. So the mandibular incisors move along the lingual surfaces of the upper maxillary incisors, and that's called protrusive. When we look at lateral excursions, that is where the mandible is going side to side. The side that the mandible is going to is called the working side. The opposite side of that is the non-working side. So there's two different lateral excursion types. And then there is something called the Bennett movement. You might remember this from dental school. This is where you get a bodily shift of the actual mandible or the condyle. Now, why is that significant? Because some people have a large Bennett movement, and that can lead to more interferences, and we'll talk about that at the very end. So when we also look at that CR and CO, we can have what is called a long centric, or some people call it a freedom incentric. Now, basically, what does that mean? That means that there's a difference between CR and CO. Most commonly, when people are locked into their occlusion, where there's very little movement, so they really don't have a long centric. But a lot of people, especially all on X cases, you will see patients with significant long centrics, and we need to compensate for that and make sure that they can slide from a CR to CO without any interferences, because that will cause TMJ problems or occlusal trauma to our prosthesis. Now, that is the static and dynamic movements. Now let's talk about guidance. So the mandible can move side to side. It can move anterior. So let's talk about the most common guidance, and that is called anterior guidance. Now, what most people don't realize is anterior guidance, by definition, includes incisal guidance and canine guidance. A lot of people use these terms, they intermix these terms, but anterior guidance is a component of incisal and canine guidance. Now, the reason most commonly in a natural dentition that we have guidance is to separate the posterior teeth. That is the goal. So with anterior guidance, how do we separate the posterior teeth? With the incisors and the canines of the mandible. So let's first look at incisal guidance. What happens, as I said, you go through into a protrusive movement. So the mandibular incisors move forward, and basically what they do as they move forward, they separate the posterior teeth. Therefore, we don't have what is called eccentric contacts. Whereas canine guidance, or some people call it canine protected, this is where the canines actually guide the mandible during lateral movements, the working and the non-working movements that I just talked about. So it is imperative that these canines, especially in a natural dentition, that they can move slowly and basically separate those posterior teeth. So canine guidance is only involving the canines. Now, with all that being said, that is the terminology that we're going to discuss today in today's webinar. So let's look at, for full arch prostheses, what are the different occlusal schemes that we have available to us? Well, first is called mutually protected. The second is called group function, and the third is bilateral balance. So these are different occlusions that can be used for full arch prostheses. Let's first talk about mutually protected occlusion. What is that? It is an occlusal scheme that basically protects the anterior and posterior teeth. And how are they protected? They're anterior guidance, number one, and posterior support. Now, again, I just spoke about anterior guidance. That means anterior guidance means that the patient has incisal guidance and canine guidance. And if you're coming in the protrusive, the posterior teeth are separating. If you are discluding off of the canines, then the posterior teeth are discluding. So the goal of mutually protected occlusion is to disclude those posterior teeth. If we look at posterior support, what do I mean by that? Well, in centric, the posterior teeth basically take most of the force. And because they take most of the force, then a lot of the force can be taken off of the anterior teeth. So the posterior teeth protect the anterior teeth from excessive lateral forces or shear forces. So in summary, basically mutual protected is the anterior teeth protect the posterior protect the anterior. Another type of occlusion is called group function. Now, what is group function? Group function is similar to canine guidance, where you do have a canine discluding, but also you have more teeth than just the canine on the working side. Meaning if you go into a right lateral, you might have a right lateral excursion. You would have the canine that discludes. You might have a bicuspid. You might even have a molar. So group function is only teeth that contact in eccentric movements on the working side. There is no contacts on the non-working side. Now, when is group function used? Most commonly, it's used in prosthetic rehabilitation when there is a poor canine, such as, say, the canine is not in good shape, it's root canaled, whatever. Then you try to pick up extra contacts to take off all the stress off of that canine. And then the third is what we call balanced occlusion. And balanced occlusion basically is what it's balanced. So you have during centric and eccentric movements, you will have contact of all the teeth. Now, This is most commonly used in dentures. We all learn this in dental school. And why? So because then you don't get the tipping of the prosthesis, and it enhances stability. So balanced occlusion is usually indicated for removable prostheses. And we'll talk about that at the end, how it relates to overdentures. Now, at our next seminar, we'll be talking about occlusion on overdentures, and we'll be bringing this concept to you, and that is called lingualized occlusion. A lot of you might not have ever done a case with lingualized occlusion, but this is probably the ideal occlusion for overdentures, and especially if you have, say, a lower prosthesis, implant prosthesis opposing an upper denture, because it gives us greater stability. And what it is basically the lingual cusps of the maxillary teeth contact in the central fossa of monoplane mandibular teeth. So usually we're using 33-degree teeth on the maxilla and 0-degree monoplane on the lower. And basically this improves aesthetics, stability, and it gives us the benefits of that balanced occlusion. And like I said, we'll be talking about that more at session 4. With that being said, now that you know all the different options, let's talk about what is the ideal occlusal scheme for full arch fixed prostheses. Well, I go back to those 3 we just discussed. And if you look in the literature, if you look at experience doing this, mutually protected is the ideal occlusion. So let's talk about why. Why is mutually protected the best for full arch implant fixed prostheses? Well, first of all, if we go back into pioneering articles in prosthetics, D'Amico in 1961 was the first to really discuss disclusion. And basically what he looked at is natural dentition. Why through evolution there's been a adaptation to this canine disclusion. And if you look at it, you know, the longest root in the oral cavity is the maxillary cuspid, 17 millimeters. The reason for that is it takes the most force and it protects the rest of the dentition. So what D'Amico found was when you disclude in these eccentric movements, it controls the lateral forces. We know lateral forces are shear forces that can cause problems for teeth and also implants. Secondly, what it does is it decreases muscle activity. So the muscles of mastication, the closing muscles, there's less activity when you disclude. So that's why that is the most accepted occlusion when you're doing full mouth rehabilitation. So let's look at some articles comparing this canine guidance versus other types of occlusion. So this is an article that evaluated basically canine guidance and balanced occlusion for full arch fixed implant prostheses. And basically what they said, it wasn't even close. Canine guidance, you have less muscle activity. Therefore, we know that patients with implant prostheses don't have the proprioception, have the ability to actually have higher increased force. And we know that force destroys our implants, it destroys the bone around the implants and or the prosthesis. And their conclusion was a balanced occlusion with a full arch fixed prosthesis is contraindicated. Other studies have looked at implant prostheses with eccentric contacts, and this even deals with group function. The top one, eccentric contacts, cause increase in prosthetic fractures, prosthesis fractures, and the bottom one increases force-related issues, whether it's a screw fracture, screw loosening, or a prosthesis fracture. So it's been well studied and well documented that eccentric contacts are not ideal for a full arch prosthesis. So what is this mutually protected occlusion? Again, the anterior teeth disclude the posterior teeth during excursions, and the posterior teeth protect the anterior teeth in centric. So it's mutually protected. So when we look at that, the posterior teeth, they're taking the brunt of the force when the patient bites down into centric. When we go into an excursion, it excludes the posterior teeth. So you can see here in the posterior where there is no contact. That is good because any of that contact will increase muscle activity. Whereas here in left lateral, you can still see. Now, we are close on that second bicuspid, but it doesn't touch. So what you want to do is make sure when you're evaluating these, you have the patient go into the lateral excursions and make sure there are no eccentric contacts that would cause these problems. And then in protrusive, what we try to get is many of the anterior teeth contacting at once so that the posterior teeth are discluded. So you can see here where there's 3 or 4 contacts on those anterior teeth as the patient comes into protrusive. So a lot of people talk about group function, and it makes sense if you increase the number of contacts on that one side, then it takes the force off of the cuspid. So again, it's only on the working side, not on the non-working side. So what do the studies show? Well, here is a study that looked at group function versus canine guidance, basically, and showed more involvement of the closing muscles with group function and greater biting force in the posterior. So the conclusion was there's greater stress generated with group function than canine guidance. Here are some EMG studies where basically they evaluated the muscles, most commonly in the masseter and temporalis, and evaluated the strength and the muscle activity when with these different types of occlusion. Basically, in this study, they found that group function should be avoided because it increases muscle activity. Another EMG study looked and found the same thing and said group function should be avoided. 2/3 of the temporalis and masseter muscle fibers will not contract when the posterior teeth have no contact. So let me put that in English. When a patient goes into an excursion, what happens is those muscle fibers of the temporalis and masseter that can be very damaging to our implants and or our implant prosthesis do not contract. So they basically don't have any force on those areas. Some finite element stress analysis tests. Basically, these are in vitro tests in the lab, and they look at the type of forces, greater stress in group function than in canine guidance. Another recent finite element stress analysis found the same thing, group function, greater stress, canine guidance has less stress. So this is an interesting that looked just at monolithic zirconia prostheses and looked at the stress generated. And basically what they found out was canine guidance had less stress than group function. Therefore, when we look at building a patient in group function, the literature certainly does not support that. If I look at my clinical history over 35 years, I have seen problems with group function, whereas with mutually protected, a lot less issues. And that goes to this study, where this study evaluated fractures. It was a retrospective study. And what they did is they looked at fixed implant fractures. And what they found was 16% of the fractures had mutually protected, over 50% had group function. So that tells you, again, that group function is not ideal. So in summary, mutually protected occlusion is the ideal occlusion for a fixed implant prosthesis. At the very end of the webinar, I'll go through the different scenarios so you can understand the different situations or clinical situations that you might contend with. What are some other occlusion principles for full arch fixed prostheses? Well, right off the bat, we want to minimize cantilevers. We know that cantilevers increase tensile and shear forces. We know that bone is strongest in compression. We know that it's weakest in shear, and then tensile is right between compressive and shear. If you look at this clinical image on the right, when you see a lot of fractures for fixed implant prostheses, they are usually at that distal abutment. Even with a good AP spread, you can have problems with the cantilevers. So ideally, what we try to do is minimize the cantilevers. Now, if you do have cantilevers, what you want to do is minimize the contact. So make sure the occlusion is less on those cantilevered areas. So if you can look at this example, you can see the bone loss by the green arrows. You can see the red arrows showing you the cantilever. And then on the lower left, you can see the blue arrows showing you the large cusps that are hitting into that prosthesis. So what you don't want are plunging cusps hitting into cantilevers. So it's in the posterior. You don't need 30 plus degree cusp angles. You have a more monoplane and a very, very benign contact. So you don't have those strong contacts where the force is going to build up and you're going to end up with a fatigue fracture. Number two, we talked about this at the webinar 1 and also webinar 2. We always want to decrease our anterior guidance. And what do I mean by that? The angle. We talked about last session about the single cuspid, how we want to disclude as soon as possible. Well, it's the same with implants, fixed implant prostheses, whether it's implant against implant or implant against natural teeth. We want to disclude as shallow and as short as possible. Why is that? Well, the longer you have of a disclusion, the greater the shear force. And the greater the shear force is going to go to that buccal plate of those maxillary implants, and we're going to get start getting bone loss. So you want to disclude as soon as possible. So the anterior guidance should be what we call as shallow as possible to prevent those type of problems. So what happens if you don't disclude? Now we have eccentric contacts, which is this image. So the maxillary teeth, when you come into protrusive, the anterior mandible is coming forward and those posterior contacts, the posterior teeth are not discluding. Therefore, you're increasing muscle activity and those eccentric contacts, which are very bad for our prosthesis and for our bone around it. Here's the study, 10-degree increase equals a 30% in load. So every time the angle increases by 10 degrees, it increases the load by 30%. So that's rather significant. Number 3, allow for freedom in centric. I talked about that. That is that short little, it's usually less than 1 to 1.5 millimeters, but that's at CR to CO where the patient slides. You want to be very careful that in these full arch prostheses, that patient has the ability to do that. If not, those are all eccentric hyperocclusion situations, which is going to not only cause stress and strain in our TMJ, but also in our muscles and our prosthesis. So you want to be very careful with that. I often get this question, what type of material, what type of prosthesis do I want opposing my implant prosthesis? And if we go back into the literature, in 2007, this article came out where it basically said if you have a zirconia prosthesis, you should do acrylic resin opposite that. If it's implant or whatever, you should try to do acrylic resin because what was the reason? You won't have the clicking, it's less expensive. However, as I said, this is a clinical report. So if you look at the literature, that is the lowest part of when we looking at a controversial subject. We like systemic reviews and meta-analysis. So what's the problem of using acrylic resin? Well, number one, it wears it out. And in the article, it basically says that you need to replace it almost approximately every 5 years. I don't know many people that want to practice where they're continuously replacing these every 5 years. The patient's not going to be happy about that. And I just don't think that is a good practice. My experience is this right here. I usually see fractures. I see excessive wearing of that antagonistic arch. So you have to be very, very careful on doing that. So if we can't just use acrylic resin, then what do we use? Well, here's a study that actually looked at it, and it's a very good study. And what they looked at is a maxillary zirconia prosthesis against zirconia. So zirc against zirc, zirconia against natural teeth, or zirconia against a hybrid. And basically, they said that when you have dissimilar materials, it leads to higher complications. So ideally, you want homogeneous antagonistic surfaces. Keep them the same if you are restoring them the same. That works the best. So, well, people say, okay, well, zirconia, I'm afraid it's going to wear. Well, if you look at the studies, very well polished monolithic zirconia has less wear than most all other ceramics. Okay. And that's multiple studies have shown that. In these two studies, which is even more interesting, is well polished monolithic zirconia against enamel is better than enamel against enamel. So basically, they're saying if you polish your zirconia very well, or as it comes back from Glidewell, no adjustments, it's actually better than enamel against enamel. Now, if you adjust it, you really do have to polish it, because non-polished monolithic zirconia is very traumatic to enamel. So I recommend you get the Bruxer polishers. It's a little kit. It has 3 different polishers in it, and it works very well. That's also from Glidewell. So in summary, if you have, in this situation, metal, ceramic against metal ceramic, that is ideal. Or zirconia against zirconia is ideal. So with that being said, now we know about the occlusion. We know how to build our occlusion. What is the ideal material? There has been many materials out there have been used for fixed prostheses. And if we look at the ideal material, first, let's look at force reduction. In the early days, Randolph talked about using denture teeth because it absorbed a lot of the force. So let's look at studies that look at, is there a prosthetic material that actually does that? And here's a study, prosthetic material has no effect on the implant or the prosthetic survival. So they looked at acrylic versus monolithic zirconia, everything in the middle, found no difference. Here's a 3-dimensional finite stress test. This is an in vitro test, not a factor. So the occlusal surface materials it's not a factor in causing bone loss and peri-implant disease or a prosthesis problem. Then let's look at the ideal material from a durability standpoint. First, we had the hybrids, which is the acrylic metal. Most commonly, it is a gold and acrylic, or now the more common one is a milled titanium and acrylic. What are some of the problems? Well, tooth wear. No matter what, even if you have it opposing a denture, because patients increase their biting force, these wear out and they become problematic. We have screw fracture problems. We have access problems. We have acrylic fractures. So can have like a delamination of the acrylic, especially if we have inadequate thickness of acrylic. We can even have substructure fracture, where it goes through a fatigue fracture from just all the force on it, especially if it is gold. So hybrids are not the ideal, and you can see where they stain and you can lose denture teeth. So that we needed something different. So probably in the late 90s, we started using porcelain fused to metal, and the technicians did a great job with pink porcelain. You could see nice stippling. It wasn't monochromatic. It was very nice. However, what is the problem with metal? Number one, when you cast that large of a prosthesis, marginal integrity was a huge problem. So just trying to get these to fit, even if they are semi-precious or even precious alloys. Then it was the weight, because we are replacing not only the teeth, but the soft tissue. We had increased weight. So some patients would get fatigue on their jaws, especially if it was in the mandible. Then we would have this large prosthesis and all this porcelain is baked on, and we would get a pop off, and then it would be hard to correct. So we would have porcelain fractures. And then the lab started soldering them. So they would laser weld them together, but then they would fracture. So then we would have a prosthesis fracture. So then we needed something else. What was that? Zirconia, but layered or veneered. And the problem with veneered is it was aesthetic. However, because there's a difference of coefficient of thermal expansion between zirconia and porcelain, it often ended up with a fracture. So that led us to the bionic material, monolithic zirconia, which is the best out there, which basically Glidewell has been there from the forefront. They have done most of the research on this. And if you look at their prostheses, whether it's their Bruxer or their Bruxer aesthetic, these are unbelievable. The strength and now the aesthetics is so much better. They've done such a great job. And unbelievable thing is the cost of this is very competitive, and they give you a lifetime warranty. So I can't tell you enough. They do more than any lab in the world on these type of prostheses. What is so advantageous of these monolithic zirconia prostheses? High flexural strength, compressive strength. If we look at less fractures, it can be very thin. This material can be very, very thin, especially when restorative space is compromised. If we look at the durability and strength, many studies have been done that show the advantages of this over other types of prostheses. If we look at peri-implant disease, and the amount of biofilm that actually attaches to it is very, very low. Here, compared 19% to porcelain's 47%, and mere fraction of the thickness. So this material is definitely the ideal material used today. Nothing better than that. And that's what I would highly, highly recommend. Okay, so I only have a couple more minutes, so let's finish this up and talk about post-operative care. And this is something a lot of people don't think about. Do I need an occlusal guard? And if I do, what type is it? Well, first of all, it should be a permissive splint or a night guard or occlusal guard, whatever you call it. The most common being a Michigan splint. So basically, it needs to be full contact. And when you build the occlusion on this, you need equal balanced contacts in centric. And then in eccentric, it should be the same type of occlusion that is in your final prosthesis. A lot of people build a balanced occlusion on the occlusal guard, which is not ideal. You want anterior guidance, canine disclusion, the same as on your prosthesis. So whether you build ramps or whatever, you need to disclude off those cuspids and then in protrusive. Probably the most common one is the Comfort HS by Glidewell, the hard soft. That is ideal. A alternative would be the complete hard one. I would not recommend a complete soft one. Complete soft one actually increases muscle activity and it strengthens the muscles, because especially patients with parafunction will increase muscle activity with that. So hard soft is probably the best for not stress distribution and protecting the prosthesis. Now, some people put it in at night, or some people have to wear it 24/7, depending on their parafunctional habits. It can be done on the maxilla or the mandible. It is basically the preference of the doctor and or the patient. Now, The type of contacts you need are centric contacts, and you want even contacts. Okay, you just don't want a couple contacts here or there. You want them equal when the patient is in centric, and then you make sure when the patient goes to protrusive that they have contacts and they disclude off of those posterior, like you can see in that lower left image. And then when they go into lateral excursions, they're going to disclude off the cuspids. You want to see a short disclusion as long as those posterior contacts are no longer round. So you can see there's one on the right side. That is one that is adjusted. So you can see the centric contacts, and then you can see the lateral excursion and the protrusive movements. Now, who should have an occlusal guard? Number one, it's going to be a patient who has parafunction, definitely. And I would almost go to say when patients have implants against implants, even without parafunction, it's not a bad idea to have an occlusal guard. They work, they take the stress, especially if the patient does clench or brux. Now, the last topic we're going to talk about is occlusal adjustment. And this is very, very important. And when you put a prosthesis in, just don't adjust it and then see the patient a month or two later. You have to do a quick follow-up. Why is that? Well, if you look at studies, and this is a good study out of JADA, where they looked at implant prostheses and they brought patients back within 6 months. And what they found is 50%, over half of the patients, actually had some change in their occlusion. So they were biting different. The muscles relaxed. They were hitting differently. So what does that mean? You need a strict protocol. Ideally, you put a fixed prosthesis in. I want to see that patient the following week. Then you can go to 2 weeks. Then after you get through the first month to 2 months, then maybe put them on a 3-month recall. Now, a lot of patients do go through what is called adaptation. And what studies, I didn't have time enough to put in, but I think it's important to note this, that most patients do adapt over time. But that adaptation is maybe a year, maybe 2 years. Every patient does it differently. So you have to be very, very careful. So if you can see this image here, this patient was brought back. Certainly, they're not cleaning it. So not only hygiene is an issue, but you want to check their occlusion also. So in summary, if we have a fixed implant against fixed implant, ideally zirconia is what we're going to be using. We're going to want a mutually protected occlusion. If we have fixed implant against natural teeth, again, this is fixed against fixed, we want mutually protected occlusion. If we have a fixed implant against an overdenture, now I'll talk about this at the next session. There are 2 types of overdentures. There is a implant-supported overdenture, which usually is a palateless maxilla or a lower without a buccal shelf. We treat that as basically a fixed prosthesis because we're not getting the soft tissue to take any of the stress. So in those type of cases, we want a mutually protected occlusion because it's basically a fixed prosthesis that just can be removed. And then our last one is our conventional overdenture, where we have a full palate on the maxilla or a buccal shelf denture on the bottom. And these are the 2 or 3 implant overdentures. And what we want with that is a balanced occlusion. And there's a specific type of balance, which we talked about earlier, lingualized occlusion, which we'll talk about at session 4 with that. So with that being said, what is our take-home message? Our take-home message is we want mutually protected occlusion. Be very careful. I know a lot of people talk about group function, but I showed you the literature out there in the studies that show the detrimental effects of that. We want a centric bite where there's simultaneous bilateral contact. We want a shallow anterior guidance. Remember, anterior guidance, there's 2 components of that. Incisal, which is protrusive, canine guidance, which is going into lateral excursions. We want, especially in these fixed against fixed cases, we want to make sure that that patient does have the ability to slide into a more comfortable position. So we want a wide freedom eccentric, or what is called a long centric. And then we want minimal force on cantilevers, and we try to also minimize even the use of cantilevers. And lastly, make sure that you see these patients for follow-up, because you don't want them to get lost to recall, and then there be a problem that is more difficult to address. Okay, with that being said, I made it with a couple minutes to spare. So
lots of time for questions. Thank you, Andy.
Okay.
Great lecture. Are you ready? Let me turn your camera on to
Oh,
to
yes,
answer.
I got it. Go for it.
Perfect. Okay. Well, the first question is, when will a new prosthetic textbook be available?
That's I used to have hair, so
That's your question, right?
Yes. No, it was supposed to be out late 2024. It should be out early spring 2025. I do have to say I just saw the page count, and the page count's going to be about 1,500 pages, which is about
1,500.
Yes, so it's going to be about 25% larger than the surgery book and the complication book.
Wow.
Yeah.
Okay, great.
Yeah.
And then I've got a question here about the difference between Bruxer and Bruxer aesthetic. You want me to take that one?
Yeah, actually, you're an expert on that, so go for it.
Yeah, so they're both monolithic zirconia. Bruxer aesthetic has a slightly higher yttria content, which makes it more radiolucent and not quite have the same level of fracture toughness. They're both plenty adequate for strength in the prosthesis, but the question, it's a doctor's choice. Do you want to have a slightly more translucent prosthesis and give up a little bit of strength, or do you want to maximize the strength? But they're both available. I believe the Bruxer aesthetic is a slightly higher price, a couple $100 more, because of the higher aesthetics and the additional labor that goes into it. Okay.
And if I have to say, Neil, the Bruxer aesthetic is, even though it's a little bit less strength, it's so far superior to any other type of material. So it's not even in the ballpark. And early on, the monolithic zirconia, the drawback that we had was the aesthetics. But I mean, Glidewell has done an unbelievable job getting that translucency, and they look very good. Excellent.
Great. Thanks. Couple questions about canine guidance or mutually protected occlusion. So if you're in class 1 or class 2 with this canine guidance, you're discluding the incisors, right? When you go laterally, are the incisors in any contact at all?
So in protrusive, the incisors will be in contact. In canine guidance, they should not be in contact. So it should be all off of the canine.
Okay, and would it matter whether it's class 1, class 2, class 3? I imagine.
Yes, it does. Unfortunately, the good news is when the patient is a dental class 1, 2, or dental class 2 or class 3, and we dentulate them, then we can build the case more into a class 1. So that we try to do it. If we're only doing one arch, and let's say the patient is a class 2, which is the most difficult, then we try to get as close as we can. But as you know, class 2 patients, anytime you're doing prosthetic rehab, they're very difficult, and it's not ideal, because then you have a skeletal relationship issue also.
Got it. Okay. And I know this really isn't on today's topic, but it's a really good question. You've got a full complement of teeth, but you've replaced the cuspid with an implant. Are we still doing mutually protected occlusion?
Yeah. So whoever asked that question, I would suggest you go back and listen to the second webinar, because I have some good videos on that. And the bottom line is definitely, if you have a canine, with an implant on one side, natural cuspid on the other, you still want to disclude. But the goal is to disclude fast. So you don't want a long disclusion, because the difference on the two different sides, the natural tooth is built to take a long disclusion. An implant is not, because it doesn't have the proprioception and it has a direct bone interface. So the bottom line is, yes, you do want that, but you want to disclude it and have it as shallow as possible.
Okay. Here's a great question for a prosthodontist. How are we going to build proper occlusion when the labs are not using fully adjustable articulators and most dentists are not using face bows? Can you get proper occlusion without using those advanced tools?
That's a $1 million question. And unfortunately, in my career, it's changed dramatically. I mean, from my father's career to mine was a change, but now from mine to my son's is over the top. Yes, you can. I believe it's a lot more difficult. When you're using fully adjustable articulators, that is ideal. Most people don't do that. Most people at the minimum or at the max now are using semi-adjustable articulators. Yes, you can, but it's more difficult and you need more communication with the lab when you're doing this. And maybe that might end up with more try-ins, but it does make it more difficult, definitely.
Yeah, definitely. A patient with parafunction, uh, you mentioned providing an occlusal guard with the definitive prosthesis. Would you provide something earlier in the process if somebody's really a Bruxer grinder kind of a person?
I mean, to be honest with you, my belief is that anyone with parafunction, okay? And if you look at the two types of parafunction, bruxism or clenching. Clenching is basically a vertical movement, which is a compressive force. So that's usually not as bad. When the patient bruxes, that's a horizontal movement, and that is destructive to everything. So say if you're doing an immediate load case and that patient has parafunction, definitely you need an occlusal guard. It won't hurt. It will only help. They're easy to make. And to be honest with you, ever since you guys came out with the hard soft, they're easy and simple. I'm used to the old school, the hard ones. It would take patients more difficulty to get used to them, and they'd be a lot of force on the prosthesis. The hard soft make a lot of sense, and I believe that is the most common one that your lab makes anyway, and it should be.
Um, we've got a doctor here who's disappointed. We thought group function was the way to go. So when do you use group function?
So group function was thought of. The reason the group function came around was if you had a bad cuspid. And the thought process was, you know what? If I go into an excursion and I get more teeth to take the force off that cuspid, that will help out. But if you look at going back to D'Amico's work in the 60s, what he found out is anytime you have eccentric contacts, it increases the masseter and temporalis. And anytime you increase the activity of those two muscles, you have problems. So that is why the natural adaptation in natural dentition has gone into canine guidance. Okay, that's our ideal goal. So is it, to be honest with you, is it a game changer in a patient without parafunction? Probably not. When a patient does have parafunction, though, definitely I think that is significant. But if you look in the literature, definitely canine guidance trumps group function.
Great. Thank you, Dr. Resnik. I just want to answer a couple of other questions here. We had questions about references from today's lecture, about recording. Okay, all of our webinars are on the website. It'll take us a couple of weeks to get it up there, but an even better reference. Dr. Resnik has written a series of 4 articles that were in Chairside Magazine, and they're all online. So if you go to chairsidemagazine.com and put in Dr. Resnik's name, all of his articles are going to come up. So he's done a series of articles on bone grafting, on socket grafting, and on occlusion, and they're all available, and all of his references are in there. So I think that's a great reference, and of course the textbooks and the upcoming prosthetic textbook, I'm sure that'll go very heavily into occlusion. Dr. Resnik, thank you for always being able to come and give us great lectures on this webinar. We really appreciate it. Thanks to the panel for your insight. We're going to be off next week for the IOX Symposium, but we'll be back on the 28th, and we'll be back with Dr. Steve Karstensen, and he'll be talking about choosing the right oral appliance for treating snoring and sleep apnea. Be sure to join us. Thanks, everybody, and thank you, Randy.
Thank you. Have a good weekend.
Bye-bye.